Good afternoon, or I guess good day, depending where people are currently. Just kind of to give a slow introduction, Dr. Kels already provided some background. I am originally Croatian, and I studied veterinary medicine in Croatia, and where I also did my PhD. I did my internship at LMU Munich in Germany, and then went on to do a residency and a fellowship in investigative veterinary dermatology at NC State. I have been throughout my residency actually involved in many autoimmune diseases, or immune mediated diseases, if you want to call them, largely because of my mentors being one of the drivers in this field of veterinary dermatology with skin immune mediated diseases, where they generally have produced a lot of papers. And then after my fellowship in 2015, I have been now at the University of Georgia. So for everyone, I am in Georgia, and that's where I'm situated. It's been about 10 years now, and I am slowly going through the promotion now for a full professorship. Regarding some of the background, how I got actually involved with colies and shelties, it's kind of a little bit of a funny story. And I have to go back to the first week of my residency when I came to the US. One of the patients that came through the emergency service was a sheltie with a disease called vesicular cutaneous lupus. He was treated initially at the dermatology service at NC State, but treated with azathioprine. So he unfortunately developed hepatotoxicity due to azathioprine. And since usually the residency starts in July, then we switched over a little bit the residents. Yeah, and I was a new person, and whoever actually treated the patient in June already left the program. And so I come in, and people ask, okay, what's going on? And I say, we suspect it's hepatotoxicity. And I talk to my mentors what we should do. And at that point, we actually realized, azathioprine was our drug to go, but it is a very heavy drug for the immune system as well as for potential side effects, including the liver damage. Yeah. So we were discussing, and actually, that was the first time that we actually realized how little we know about these diseases. And I'm talking about 2011. So if you think about it, it's not that far away. But still, it is, it was a time where we did not know a lot about certain diseases, specifically these diseases that affect colies and shelties. So back in the days, my mentor said, okay, you go ahead and you talk to the owners and, you'll figure it out. And the owners usually would say, what do you recommend now as a treatment if this doesn't work? And being a very fresh resident, I was a little bit, caught up. And I said, why don't we start cyclosporin, which is another medication that we use for immune-mediated diseases, although we had no evidence it would work. And, the owner said, is that, how many patients have you treated with this? And I almost fell apart, yeah, because this was probably the first time I even saw this disease ever, yeah. But from there, we worked up, after a few years, we got a dozen of cases that we were treating with cyclosporin, with vesicular lupus in colies and Shetland sheepdogs. And we would say that largely we have had some success, but there were also patients that did not respond. So that would probably be, I would say, the first week of my residency. When I arrived, I got a little bit the first introduction to a very unique disease that affects these breeds, which we do not see in other dogs, which is really fascinating and interesting. And probably some of you may have had dogs with such a disease. Now, if I move a little bit forward with the next slide, I guess, do you want to do any questions, Nancy, during these slides, or?
Are we able to have people put comments in the chat or anything,
So
Roxanne?
yes, for people who are attending, you should have a Q&A function as part of Zoom, and you're able to ask any questions. At certain points during the webinar, I can either read them out or allow you to talk to ask a question.
Okay. Yeah, so thank you very much. If you could, if you could do that, because I'm not sure if I can see them or I have to go click around until I see the questions. So to continue a little bit, and I guess I'm the first person doing this, so I guess we still have a few things to sort out how we do this. I guess this was a slide given to me kind of asking questions and challenges setting to start this work. Now, the only questions that I have is, I presume this kind of alludes to the work I did in autoimmune diseases generally, or is it pointing out to the work related to the dermatomyositis or lupus or?
Yeah, I think it can be some of the work you performed, but as well as the, I know most of these are Kali and Sheltie people interested in DMS and the VSL as well.
Okay. So in general sense, like I pointed out, that was the first time I started seeing the disease. Interestingly, when I was in Europe, I was just doing a rotating internship, so usually was not exposed to as many dermatology cases as during my residency training. But during that time, I always found it interesting how these autoimmune diseases, first of all, how they look and how they can be very refractory to treat. Now, that can also happen to us with allergic skin diseases, but in general sense, I would say the vast majority of allergic dogs tend to have usually a good quality of life, considering like what type of drugs we have to control their diseases. But with autoimmune, it was always a bit trickier. And so during my time as a resident, I generally started accumulating as many cases as I can of various autoimmune diseases. And the first one that I was seeing a lot actually was vesicular cutaneous lupus. Occasionally, we would see a few patients with dermatomyositis, but it wasn't as interestingly as prevalent there. I would say maybe people know, of course, what it is, and then they do not always visit a dermatologist, maybe unless the case is very severe, and deal with it on their own way. But what the first solution for us is to figure out, at least among the drugs that we have, because that's the first thing we have to do, is treat the patients. We would like to investigate more the pathogenesis of the disease, but that usually requires time and money. And when I was a resident, none of those things were actually accessible to me. Now, when I became a professor here, became an assistant professor, then usually I had access to my own lab and had access slowly to the students. So that generally prospered the things much faster from my perspective. Now, regarding the findings that we found, well, when we were studying, vesicular cutaneous lupus, we found out that cyclosporine can help, but we also found out that not every patient does go into remission, and there are some that are very refractory to treat. So the next thing that we wanted to investigate more and more is actually like finding out what type of lupus, what is the drivers, or what are the immune markers and drivers in the lupus of the skin in the dogs. And for that, the biggest challenge that we had is to find patients that we can collect fresh samples. And so we had more luck with certain lupus types in dogs, such as, discoid lupus, which, sometimes a long time ago used to be called sometimes like Collie nose, yeah. But we used to find more other patients like German Shepherds and Labradors, and we used to see those in the clinic. So obtaining fresh samples from there, usually we started understanding better and better the disease by doing special techniques and understanding what type of immune markers and pathways are actually causing the disease. And that led us into the field of the JAK inhibitors. The JAK inhibitors, or Janus kinase inhibitors, are small molecule inhibitors. They are, of course, you will see them on the TV for human diseases. But we have been lucky that we have gotten a drug in that class early 2013-14 when I was finishing my residency. So we started seeing that pathway was really highly upregulated in discoid lupus. And then we propose likely that may even happen in the vesicular lupus because they are so resembling diseases. But that's a part of the work that we are still working on. And we started implementing that medication, and some of the patients, it has been really helpful because they were not cyclosporin responsive. So I'm pretty sure that many responded much better when we started introducing the drug. Also, with the dermatomyositis, we have tried the same. That was a study that was funded through the foundations and Kennel Club or AKC, basically, yeah. And in the end, what we found also is that dermatomyositis shares a very strong JAK pathway or a JAK-STAT pathway, to be more accurate, in the lesions. However, what we also saw is that oclacitinib can help these patients, but if the scarring sometimes is very severe, we may not be able to reverse that. So that was a little bit surprising because we were hoping that we should be able to reverse some of that as well. But I guess now the next step is to look into like stem cells and figure out why do these stem cells not repopulate hair follicles and we are seeing the hair regrowth. It's quite possible that there is not enough of them, but at the time being, I would say we do not know 100% until we research more. Now, what's also surprising is that although some of the lupuses, they look different, if you ever have seen these dogs, there are different forms of lupus on the skin, like discoid lupus on the nose or around the eyes, and then vesicular lupus, which usually makes this very unique ulcerations, erosions, usually in the areas of sun exposure. It's very sun exacerbated. They do share similar molecular profile, but what we are very keen on in understanding is that they're very similar type of cells do the same thing in these, and our techniques so far have been limiting. So we are hoping with some of the future novel techniques that we have available in the dermatology world that will be able to decipher more and more the pathogenesis of these entities, because they do behave a little bit similar, but they look a bit clinically different. So there has to be something else in there that we are still missing in the whole story of figuring out these lesions and how they develop. Now, I do not know if there are any questions there, or I need
Yeah,
to.
we have a few. So
Absolutely.
first we have someone who asks if you have any slides on what vesicular lupus appears like on the skin of affected dogs. Or if you have other or pictures.
Yes, I have. Now, if I just stop sharing for a second, and you can ask the other questions in the meantime while I pull the pictures. Yeah, I'll show the picture.
So in the meantime,
Yeah, if you want to ask this.
there was a question on cyclosporine in collies. I believe it is what we call an MDR1 problem drug, where some dogs react adversely to it at much lower doses, I believe. Right, Nancy?
Yeah, potentially the double mutant dogs receive a lower dose at times.
Is the screen visible?
Yes.
Yes.
Is it the duplicate or is it the presenter mode or normal mode? You have a normal mode that you can see the whole slide?
Yeah,
Or is...
I have. We see the normal mode,
Yeah,
not the
so
presenter mode.
yeah, so this would be an example of the vesicular lupus. As you can see here where the lesions are, and we always consider it to resemble the human subacute cutaneous lupus a lot, how it looks clinically and how it gets exacerbated with the sun. They don't tend to progress to systemic SLE, and they tend to develop at various ages. We do not think that there is a gender predisposition at the time. And we are collecting DNA from these patients with our collaborator, Dr. Leon Clark, to figure out if we can figure out the genes, what's going on. We do not know. We don't think it's going to be one gene. Likely it's going to be multiple. But these are the so-called very classic macules that tend to progress in these annular to polycyclic lesions, which you can see with vesiculation, erosions, and ulcerations. They almost appear in some areas like serpiginous, like snake-like, yeah, how they develop. So they are very unique. Sometimes they'll be like fully ulcerated. Usually the patients will get fully infected here. There'll be a secondary staph infection, and not sometimes, but commonly that can be multi-drug resistant. So we have had patients with that, and then they usually have been given very severe very severe heavy antibiotics for the body. They either will cause some kidney damage or liver damage. So that sometimes complicates the treatments. And when we look at the location, yeah, these are the spots that very commonly have these lesions. We see it absolutely in the mucocutaneous junctions, but in general, the areas that tend to be, I would say, more sparsely haired maybe, and where you have a more sun exposure, they tend to have the lesions. But again, it can also go in the oral cavity, the lips, periocular, inside the ear here. That's how these patients look. So I hope that kind of clarifies how they are clinically distinctive if you look at them from dermatomyositis. So dermatomyositis looks a bit different than this, yeah? Although it may appear to you maybe like for us, like trained people in dermatology, dermatomyositis would never cause lesions on the belly that look like this. Usually we would not expect that. So I'm going to stop sharing if that's okay.
Yeah.
That slide.
We have one more question.
If
Does
you,
VCLE happen only in collies and shelties?
yes, to our knowledge, there have been some reports of potentially Australian shepherds now, but we are unsure about that. The main differential is something that we call erythema multiforme, and that's a very unique immune-mediated disease that also causes erosions and ulcerations. And in the general sense, we are unsure about the shepherds if they actually have erythema multiforme versus the vesicular cutaneous lupus. But some people are trying to pitch that story more. And then I forgot actually to show you because I do have a slide, I guess, for the dermatomyositis, so I can show you that. If you are asking yourself, how does this look and how does the DMS look? Yeah. Well, the DMS will be different, yeah, than these lesions. And you can see here what we expect. This one tends to be more erosive to ulcerative, and the DMS usually tends to be not in that fashion. It tends to be more alopecia, and there are sometimes scaling or crusting, more hair loss, absolutely, nose depigmentation, hair loss in certain areas on the feet, and sometimes also the nail folds and the nails. So clearly they are different. The question that we are now raising, of course, is, molecularly how different they are and what are we going to find in these, because that would be very, very fascinating to see. Now, for both diseases, interestingly, we will use a JAK inhibitor because many cytokines and growth factors, they signal through the JAK pathway. However, there is a difference probably between them, and some tweaks depending what type of a JAK inhibitor could be more efficient in one disease or the other disease. That's parts that, those are the parts of the puzzle we still do not know. And that's what we are very interested in understanding. And then someone had a question about P-glycoprotein. I'm sorry, I did not catch that.
Oh, yes. Cyclosporin is a P-glycoprotein substrate, correct?
Absolutely, yeah.
Yeah, so an MDR1 problem drug for the collie people in here. Yes. So I do believe, yeah, there are dose considerations when treating with cyclosporin.
Well, I mean, we usually give them the dosage we would treat other immune-mediated diseases. Now, whether that affects our efficacy or not, that's a good question.
Mm-hmm.
And we usually don't check the breeds, or we don't check the collies and shelties that we have treated with cyclosporin, whether they are mutants or not. We have been checking those patients in certain medications, such as chemotherapeutics and ivermectin. When I used to be a resident, a while back, one of the ways to treat demodicosis was with ivermectin, and we know the toxicity of ivermectin and the P-glycoprotein, or the MDR. So the question that I would have to ask probably the expert on that field, I think, is the person in Washington, if I'm not at Washington University, is actually have they run the PK and just check the curve in collies and shelties when they are given cyclosporin, if they are mutants, whether they achieve the same blood levels or not. And I am not sure if I have seen a paper on that, to be honest, but it's actually a good I guess it's not, I mean, for people that know their status, it's not that hard to evaluate the blood levels of cyclosporin. Because maybe some of our non-responders were actually mutated, and maybe they were not achieving high blood levels. Or actually, on the other side, they should be achieving higher blood levels, because cyclosporin would not get pumped up if there is an MDR mutation, theoretically speaking.
Yeah, it's generally a well-tolerated drug, and I know Dr. Bealey out at Washington State will do consults for dogs that get tested through her lab and make advice on that. But generally, the dosage have been pretty similar to the standard dosages in the couple I've done with her.
Okay. Yeah, we have not, for the people here, we have not tweaked our dosages in a way of lowering them down, but we are very careful when we combine any type of medications with the P-glycoprotein substrate drugs. So azoles and certain medications, they are not, we are very careful to do that, because we can increase the blood levels of the drug very substantially, or a lot, and that there will be side effects or GI upset and other things can happen. Yeah, and then there was another, I'm not sure if that helps clarify, but there was another question, I think I forgot. Well, I was showing pictures, and I'm not sure if I understood or heard it well.
I think most have been answered. We have a few who are like about specific dogs treated for discoid lupus, that were triggered by a ProHeart injection, the 1 year heartworm injection. And the owner is asking, the owner was treated with tacrolimus and doxycycline and niacinamide. She asks any thought on this treatment, and if certain meds and environmental exposure could cause the lupus.
So very simply, we really do not know 100% why, just like in people, some people have it and some people don't have it. So there has to be probably a multiple factors genetically that give you the predisposition. Trigger-wise, ProHeart, I guess it's always very hard to show this, because the only way you can sometimes show things is to re-challenge the patient and see if it gets worse, which probably no one wants to do. Unfortunately, we don't have great studies where we can kind of pool blood from patients and expose drug to those lymphocytes or those blood cells and see whether they suddenly proliferate far more than they would usually, and maybe that will show the sensitivity to that drug. Sun is a non-exacerbator of lupus in people and dogs. We have had patients on medications that get constantly sun exposed because the owners let them sunbathe, and our drugs don't work that well. So we have seen that in the clinic. So absolutely, you should have tried to avoid any large amount of sun exposure to the dogs if you have a discoid lupus. And then finally, that type of a medication is a standard of care for decades. So tacrolimus and doxycycline, niacinamide. Doxycycline is an antibiotic with some immunomodulatory properties. We are unsure exactly how does that work and what's the efficacy of that treatment, because we don't usually have great controlled trials in any type of lupus. It's usually open label studies, which means we give drugs and just either dogs get better or don't, but there's not a control group that gets a different drug. So at this stage, if it works, depending how the lesions look like, then it's good. And then probably doxycycline and niacinamide would be tapered down, and tacrolimus topically would be kept, because if you can prevent the dog from it seems like a reasonable treatment. Now, if this should fail and the dog nose is not getting better, or it's still inflamed and red, then usually we would tweak the treatment depending which options we have. And then usually that the drugs that we use these days will be a JAK inhibitor like oclacitinib or apoquel. But we will also tweak our dosages there. Once we get better, we want to taper as much as we can. So that would be the way to do it probably. And I'm guessing, I have not seen the pictures or the biopsy findings and then how the patient was diagnosed, but just as a theoretical, if it is truly a discoid lupus.
Awesome, thank you. I'll let you continue and I'll come back later with further questions. Thank you.
Okay. So we are back at the slides, am I correct? And
Yes.
you all can see the slides. Yeah, so the next line that we had is collaboration and any questions about the and any input on the research group. Yeah, so one of the really nice features of being a veterinary dermatologist is that we have a very large community worldwide of different types of colleges where we all do our residency. So there is an Australian College of Veterinary Dermatology, there is South American, there is North American or American, then there is also European, there is Asian, there is even now a new college in India. So there is really a large amount of people that are interested in this field. And what's very cool is that usually every 4 years we have a World Congress of Veterinary Dermatology, which switches continents. So it moves around between different areas so that every continent gets to a large percentage affected, and it can bring the popularity of the discipline to a different level. Now, because of that, because we have such a large community, we also have a lot of listservs. So one of the really convenient things is that I can reach out so many people via emails worldwide, many dermatologists or people interested in dermatology. They don't have to be boarded in their areas, but just have an interest via different listservs, and I can ask and find potential patients. And that's one of the ways we have received many DNA swabs from the vesicular lupus patients worldwide. Just last week, we got some from Lithuania in Europe. We got one from Finland. We got 2 from Sweden. So by basically reaching out to the listserv, we always find people, and then we screen patients for the clinical findings, the history, the biopsy findings, etc. And if they fit the criteria, then we submit our swabs through the mail, and they return it back to us, and we get usually what we need. Now, that is a very convenient way of getting things done that, DNA is stable, so it doesn't have to be immediately collected here in the facility. Now, regarding the research per se, we collaborate with several groups. We are very thankful to have Dr. Leanne Clark, who investigated the genetics of dermatomyositis in collies and Shetland sheepdogs. She's maybe like about 10 minutes away from my office. So she has many students, and all our DNA swabs from the VCLE dogs go to her now, and she's analyzing those. Just as well as during our dermatomyositis studies, she was collecting all the swabs. So we have a geneticist there. And then, unfortunately, there is not a lot of veterinarians who do lupus or dermatomyositis research. I think that's generally like probably across all kennel clubs. If there are certain diseases that affect the certain breeds, there you don't usually find 10 people investigating that disease. But what we do have access to is a lot of MDs. And dermatomyositis in dogs was proposed in 1990s to resemble juvenile dermatomyositis of humans. And we have collaborated and shared some of our data on molecular markers with human groups or groups of MDs with research in lupus. We have not done that with dermatomyositis, but we have established contacts. And it's usually very cool because, we live in a time where this approach, one medicine, is very important. One health approach is there because, what affects humans tends to affect dogs as well, and cats and other animals. And there is a large incentive to understand it across species and not just, focus always on the humans. So wherever we have reached out, usually we have had a great success and a great feedback from these people. Now, regarding the active collaborations, like I pointed out with Dr. Leanne Clark, we have several, but I would probably say regarding the Collies and Shetland Sheepdogs, we are focused on the VCLE, and she still analyzes all the DMS samples for us. And then regarding the lupus part, we are, collaborating with some people at University of Bonn in Germany, where they analyze subacute cutaneous lupus. That's the variant that resembles a lot vesicular lupus in Collies and Shetland Sheepdogs. So we just want to see if they can share some of their molecular signatures, that we see how much they really resemble once we start analyzing ours. So absolutely, it is the world is big, and so far we have always had great success in getting feedback from people. But unfortunately, from the veterinary side, we wish there were more collaborators, but it's hard to get those. Now, what is an easier thing to do is sometimes if we need samples, all of our dermatologists that are spread out in the US, if many people here are from the US, but sometimes even abroad, usually they will collect biopsies for us, or they will collect blood for us once we instruct them what to do. And we have had our study with DMS. There were several samples collected by board dermatologists, and that worked very well. So we always can find, usually depending where you are, can find, someone that is trained like us, and then we can communicate to tell them exactly what we need if the patient is undergoing biopsies. So I'm gonna keep on then going, unless there is more questions and I need to stop.
I think actually the questions are relevant to this slide. So yeah, please go on.
Okay. So yeah, so the research focus, so kind of our lab, and I always try to explain this a little bit. So my lab currently has 2 PhD students, a technician, the dermatology service. We have 3 residents, we have 3 faculties, several technicians, and then currently we see about, I would say probably about 2,200 patients a year in dermatology here at UGA. Largely, we would see far more than that, but we have students on every rotation, and we are a teaching institution primarily. So not, I would say not, research only and not money driven only. Because, if I was working in a private practice, usually I see about 15 to 20 patients a day, if not more. But it would be very hard to do that when we have several students. We have to teach the basics. So our lab here usually is completely externally funded, and largely the biggest chunk of the market, I would say, in veterinary dermatology currently is allergic diseases, and specifically atopic dermatitis. So we have a lot of, I would say, pharmaceuticals who usually contact us if we can test some of the novel drugs, and that's where some of our funding comes from. And even if we kind of don't want to do that, sometimes it's just the only way to fund a resident or the only way to fund a PhD student has historically been pharmaceutical driven, because I would say, the market is such a huge market for them, and they all want to develop novel drugs. The autoimmune skin diseases, unfortunately, are usually rarely funded. And I guess in humans, they are, first of all, rare, like in dogs. But I guess in humans, we have NIH, which I believe still has the funding, and the NIH can help fund rare diseases. So they'll go in and do that in far better and far more efficient than we can do in veterinary world. If I take 10 patients I see today, probably 8 have a allergic ear or a skin problem. So it's so prevalent that majority of pharmaceuticals tend to have an interest in something that's more prevalent and then for them brings a better market and I guess more revenue. Now, our lab has a very broad interest in autoimmune skin diseases, and in the last few years, we have focused on the lupus, and then I would say probably about 5-6 years ago, started focusing on dermatomyositis as well, and the treatments, of course, because while we want to understand the disease, we also want to bring something new to the table with the novel drugs to see whether they will help or not help. So those are kind of the I would say the biggest interests that we have and what we do here. Now, usually for many of these patients, we always love to see them here where we can collect all the samples we need. But unfortunately, that's not always the case. That's that easy for people to travel. The US is a pretty big country, so if we cannot do it here, then we usually work with veterinarians, primarily where the clients are, or we will work with veterinary dermatologists if they are nearby and accessible. So those would be basically like, I would say autoimmune skin disease is something we really want to help because it's something that we see and it can be terrifying to treat. However, largely our funding has been in the past going through the allergic pipeline. And like I said, many pharmaceuticals tend to reach out to us from Zoetis, Virbac, Siva, if we want to test novel ear medications or novel anti-allergic medications, because at the end of the day, that's probably what drives their market. So that's probably that for the research focus. I'm not sure if there are any questions related to this slide or I need to.
There's a couple questions related to oclacitinib and treatment. Do you want to move forwards or do you want to answer them now?
Oh, I can answer them now.
So the first one is you talked about cyclosporin and JAK inhibitors. Do you prefer using cyclosporin over oclacitinib or vice versa, or no preference? To treat VCLE, sorry.
To treat VCLE. So in general sense, these days, I would probably, based on what we have, and we have not published new data, but what we are preparing a preparation. We are preparing a publication on VCLE soon to come out. We would say that oclacitinib would be our first line now, but there are tweaks in the system. So oclacitinib is labeled for atopic dermatitis and allergic skin diseases, anti-itch drug, etc. However, when we use it, we use a little bit higher dosage, so that needs to be explained to the clients. And what we do, we also check the blood work, because when we use off-label medications, meaning like if we increase the dosage of a medication, we want to be sure that there are no side effects. In our experience, it works without any side effects. We have not had any issues, but we still keep on checking just because, our sizes of samples are not like hundreds of patients, but like 10, 15. And it's usually oclacitinib would work faster from the perspective how it works, because for cyclosporin, it takes a little bit time to work. So we usually will say 8 to 12 weeks, and we usually bridge it with steroids. Sometimes we will give oclacitinib and only use like topical medications, like topical steroids or tacrolimus, and we will not give any steroids orally. So I would say probably for VCLE these days, oclacitinib. However, there is a new JAK inhibitor that's called Zenrelia. It's called, brand name is Zenrelia. The drug is called ilunocitinib, and that is a more potent JAK inhibitor. We have not tested that yet, and reason for that, because it's more potent in a way how JAK inhibitors work. This one would also have potentially more side effects, and there is an FDA label that you have to stop the drug for getting vaccines. So the drug is absolutely a more potent immunosuppressor. So we would probably do oclacitinib and stick with that as a JAK inhibitor, unless we kind of have more severe patients, and then we would enter the other one. Although the other one would also needs to be tested. Maybe, in the end, it will work much better and faster, and then you may not need a lot of drug long term and not need to worry about the vaccines and stopping the drug. But I guess it's a preference.
Yeah, that actually answered another question from an attendee who asked if you are using other JAK inhibitors than oclacitinib. So thank you for.
Absolutely. And then Zenrelia is brand new. So we have started to use it where in few patients with atopic dermatitis and few patients with pemphigus, but we have not ventured a lot into it yet. Every time a new drug comes, as a center, we do not jump the boat with it. We want to wait a few months, a year to see what people publish and to see what's going to happen. Because sometimes if we see severe side effects, then we cannot retract back, and we prefer to have some background knowledge when the publications come out, etc. Now, another tool that is very interesting for us is in my lab, we have been trying to work with topical JAK inhibitors. So we are testing now some variations of these because we would like to have also a topical JAK inhibitor then rather than just the systemic ones. They would be probably not bad compared to topical steroids because they would have far less side effects of topical steroids. And also compared to tacrolimus, they should not sting because some of these ulcerative lesions are open lesions. And when you put tacrolimus on that, that can sting the patient through a special pain receptor that is known in people and dogs. It's almost like putting red hot chili pepper on the wound, and that stings and is painful. So that's another venue. In humans, you have several registered products already as topical JAK inhibitors worldwide. The problem is that we cannot access them here in the US because of the pricing. They're just way too expensive without a script.
Thank you. And then a third question, have you seen any patients develop tumors after being treated with oclacitinib?
Yeah, absolutely. So we have had patients that were treated with oclacitinib, but I would probably say usually off-label use for a very long periods of time, that we have seen sometimes hemangiosarcs or we have seen osteosarcs. The problem becomes is that they are usually older dogs, so we never know if that would have happened nonetheless or with or without oclacitinib. There was a retrospective study that looked at the incidence of tumors in dogs on oclacitinib or not on oclacitinib, and they concluded that there is no higher risk on oclacitinib for patients to have to develop cancers. But personally, if I was getting treated with a JAK inhibitor, I would prefer to use the lowest amount of that drug I need to control my condition, and I would be afraid to use the drug daily forever. So if in any time I treat any autoimmune disease or immune-mediated disease, I always tell the owners to lower the drug down by using the topicals to the lowest amount we need to control the condition. Sometimes the owners don't understand that and they keep on going twice daily or off-label use. I would not do that. So while I don't have evidence that there will be cancer, I do not want to suppress the immune system that much to potentially give a chance for something to develop. So it's better to block if you can or lower your dosage down, as much as you can. And that would be probably the best way to approach it. And that has worked very well. Like we have had patients with vesicular lupus that get maybe oclacitinib twice weekly. We have had patients that stop it in the winter and then sometimes it comes back in the spring and they give it for a few days. At least vesicular lupus is a very unique disease that can sometimes wax and wane a little bit in some patients, not all. But absolutely, like in people, I'm always afraid of any immunosuppressors long term. So I'll try to use the lowest amount I need.
Thank you. And then there's a different question. An attendee's asking about MRSA. Do you see MRSA in these in unaffected dogs even? Do you see a lot of that?
So I presume are we talking about dermatomyositis? So dermatomyositis usually not. We really don't have a lot of issues with any staph infections in dermatomyositis. They don't tend to get ulcerative, and you don't have a breakage of the skin barrier, so usually we don't have infection. If it's the vesicular lupus, yes, we absolutely see, but it's not MRSA. MRSA is methicillin-resistant Staph aureus, so it's a human staph. We usually, okay, if people really like somehow touch that wound all the time with their nail, touch the nails, that's where the reservoir is, and then you touch the wound, you may transfer the Staph aureus to the dog. Usually the Staph aureus is not really adopted to the canine keratinocytes, to the skin cells, so it's not going to stick well. Dogs have their own staph, which is called Staph pseudointermedius, and we see commonly methicillin-resistant Staph pseudointermedius in these lesions. Now, when I treat that, I actually don't give any antibiotics. I completely ignore that. I concentrate predominantly on treating the skin lesions by reversing the immune dysregulation. And then I only use topical antiseptics, let's say chlorhexidine, and topical antibiotics to try to reverse that staph dysbiosis. Once the immune condition gets controlled, usually the normal microbiome, the normal bacteria come back, and usually we don't have the issue anymore with drug resistance. But I have had many patients that get referred to us on chloramphenicol or rifampin, or like we have seen this. These are very heavy drugs on the patients. They can damage the liver, they can cause bone marrow suppression. So we prefer not to use those. We generally just concentrate on treating the immune condition. And the staph is just secondary there. It's not the driver. Usually that works very well.
Thank you.
Okay, so I'm gonna then continue to the next one. So yeah, okay, so there are a few questions about the lupus in dogs, and actually probably the best thing to do here is maybe share a slide. How similar and how different they are. Stop share, and I'm gonna share a screen just to show everyone how they look like. And so I presume everyone can see now. Is it the presenter's mode or the other mode?
Currently, it's just kind of PowerPoint not presenting.
So now it's okay?
I mean, we see the images. Yeah.
Okay.
Perfect.
Yeah, all right. So basically, there are absolutely several variants of lupus, and we'll try to clarify what we know now. So in the very simple classification, we tend to, in humans, there is an acute cutaneous lupus, there is a subacute and a chronic. In dogs, we do not have an acute corresponding variant. Usually acute cutaneous lupus develops as a so-called malar rash, butterfly rash on the cheeks here, just below the eyes. Usually people get that with systemic lupus, and they'll get like red rash, and that's so-called acute cutaneous lupus. And then it stays there a few days, and then it goes away. The chronic cutaneous lupus usually is a type of disease where it develops, the lesions don't go away. So the lesions tend to stay. If you don't do anything, they will just progress, sometimes more, sometimes less, but they do not go in remission on their own. The subacute lupus, like what we also consider in people and what we see with vesicular lupus in collies and Shetland sheepdogs, sometimes, depending on a patient, it may wax and wane. So sometimes you'll see some of these lesions, depending on severity, if they're very mild, they can get better, and the owner will be like very pleased. But then after 2 months, they'll say, oh, new lesions are coming out and stuff like that. So that's why it kind of corresponds to the subacute. Now, the chronic lupus, like I said, once it develops, it tends to stay. Oh my gosh. And there are different variants of that. And how much they are alike or how much they are different is has been a little bit historical. Our classification is not great. But there are some that affect the bridge the nasal planum and the bridge of the nose, and sometimes also go to around the eyes, the lips, that we sometimes call facial discoid lupus, where you'll see this depigmentation and loss of cobblestone appearance, and then erosions and ulcerations. And sometimes this spreads through the rest of the body, and it comes with these depigmented discs, and it's called generalized discoid. And then we also have an exfoliative lupus that affects German shorthair pointers. It's a mutation that is known, and basically they develop it in a very young age usually. We have clarified the mutation, we know what it does, and they will develop this exfoliative scaling disease where they will lose all the hair coat. They also can get depigmentation. And then finally, there is a mucocutaneous form, which usually affects German Shepherds, and it will affect mucocutaneous junctions. So junctions between the mucous membranes and haired skin, such as like perigenital areas or perianal areas. So you're going to see erosions and ulcerations in those areas. So those are the kind of the types. There is logically sometimes patients with mixed variants that can happen as well, and they'll have some features of one and the other variant. The variant for exfoliative lupus, the UNC93B mutation, has now been found in mixed breed dogs as well. And we are wondering slowly how prevalent it is, like worldwide, because we initially thought it can only be German Shorthair pointers, but we are finding it in some Labrador mixes. And so we have to figure out the ancestry and how is that happening with them. But it may be more prevalent than we initially thought. The other ones, we have not found the mutations for any others except the exfoliative lupus. And also because it's a very unique mutation that in a mice, when you mutate that protein in a mice, you get systemic lupus. These German shorthair pointers, they do almost like go into a systemic lupus. They progress. So it's a very unique variant from that perspective. Usually the collies and Shetland sheepdogs, they do not develop lupus nephritis. They do not develop hemolytic anemia, thrombocytopenia when they have lupus. So that's not a feature of the disease. So now what is one of the focus of our lab is to try to figure out how pathogenesis-wise are these all different, and do they have any unique pathways that are just unique to one versus the other one, which we could potentially target in the future. So the question that becomes here, if we give like cyclosporin, which variants respond better and which variants respond not so great? If we are giving cyclosporin to exfoliative lupus in German shorthair pointers, it usually doesn't touch it that well. They don't do well on it. So, but we have figured out that, combination of certain drugs does better. So that's the part that we are trying to figure out. And that's probably going to be one of the keys in the future to understand the disease better, is to figure out what exactly is driving these across when you do comparative dermatology, which at the time being no one is doing. And that's probably one of the things that, our focus, we just want to try to figure that out. Now, can the conditions be cured? Well, if you have a genetic mutation in German shorthair pointer, then no. At the time being, if once it develops, for instance, in that breed, it's likely genetically there. We can manage it, and sometimes we are more successful, sometimes less. The other dogs, we do not know their mutations, and it could be not one, it could be polygenic, and there is additional triggers. Usually when I would say when we have lupus, we usually manage it. Like if someone is expecting a full cure, I think the best variant for that will be probably like vesicular lupus, where we actually see some patients where we can stop the drugs. But I would say in many patients, it tends to come back at some point. Now, again, we don't have high data on this in a way that we follow patients for decades. But many of the VCLE patients, I have been in contact with the clients for a long time, and they'll just email me and say, oh, this summer it came back again, and I started using the drugs for a few days, and now it's better. And so I wonder if, I don't think it's that easy to get a cure at the time being. I think like in people, you have it and then you just manage it, and sometimes you get better, but not always that you can stop the drugs forever. Yeah, and I do not know if there are more specific questions about the slide.
We have a question, but it's not super related on this slide. It's about a attendee's dog who had a sterile granuloma and pyogranuloma syndrome, which was confirmed by Path. And he was treated with Temarol P and for the steroid, and then they switched to Apoquel.
Yes.
And then they say the lesions cleared up, but he's scarred. And gets some like little lumps on his ears. The attendee is asking, like, does this process only happen on the skin, or can it also affect like internal organs, for example?
Usually this, well, it can affect sometimes internal organs, but usually it's just a skin-related disease. We do not know the trigger, but you basically have certain blood cells or certain immune cells like neutrophils and macrophages. That's why it's called pyogranulomatous, and it just something triggers them and they start developing the plaques or the bumps, which we call bumps, all over the body. And usually they'll rule out all the infectious agents that could be causing that and then give you immunomodulators if they cannot find any. Now, I'm not sure if Apoquel is always the best treatment for this condition because that's a bit tricky, and I would say probably historically we have used more cyclosporin for this condition because of the cells. But I have had not many, I have had some patients that resolve on their own and it doesn't come back again. So it's a very weird syndrome, probably of multiple entities. Some do, like somehow they get better and it goes away forever and we stop the drugs, and some, keep on having the lesions. So not sure that entity requires more research. It's a very unique entity. It's not a clear cut like these. What we are seeing here is they all look very similar. That sterile pyrogranuloma syndrome is very diverse clinically. It's heterogeneous, which means likely it's also treatment-wise heterogeneous. Yeah.
Thank you so much. We don't have any other questions.
All right, perfect. So let's go ahead. Yeah, so yes, so dermatomyositis and lupus is the next slide. So I already kind of pointed out the clinical differences between them. And clinically they differ, absolutely. So what we know is that in dermatomyositis, we believe the vessels are getting damaged and there is a lack of oxygen. And that lack of oxygen and nutrition likely leads to the symptoms where the skin cells start dying and they get damaged, they get certain degeneration that happens with the hair follicles as well. And then you get basically loss of hair, or hair loss or alopecia. On top of that, you are starting to get fibrosis and scarring. Now, some lupuses like to scar too. So the same principle, but with lupus, it's a bit different. The problem is not the vessels or vessel damage. Actually, the problem is a T cell or lymphocyte response against keratinocytes. There are certain, we would call them antigens, or they are like certain proteins that get expressed by your skin cells, and then your normal immune response suddenly comes in and wants to kill them. And we just do not know what those proteins are, but that's what happens with lupus. So while they have some similarity, they will affect certain breeds and this and that, but clinically and histologically, they are different. Now, what we do know is usually, like I showed in the pictures, it's relatively not that hard to differentiate these for a trained eye, but it does become a problem because, this is the only thing we do all day is just look at the skin, and not everyone looks at the skin as a veterinarian only, yeah? So they have so much work to do with everything else they do. So how can, a protocol that can help breeders? I would probably say the best thing to do is for us to keep on publishing. And as we publish and as we produce more data, which probably needs to happen. I mean, dermatomyositis is a disease. If you try to find latest research, it almost stems like 20 years ago, was the time when they evaluated pentoxifylline. It's been 21 years ago that someone has published on the efficacy of pentoxifylline in dermatomyositis. So that tells us that, unless we raise this to a level and we start, publishing very nice pictures and clinical papers where you can see the differences between these, and these get uploaded on the websites for free, and then the Kennel Club can promote among its members, then people will start saying, oh, my dog looks like this and my dog looks like that. And that would be the only way. The other way to do it is to have your veterinarian consult a veterinary dermatologist. So depending where you live, usually these consults are free. Like we offer consults free to every veterinarian in Georgia and South Carolina until they establish their veterinary school. So pretty much all of our, veterinary students, tomorrow doctors, can ask us for opinion. And you can always ask that, is there a dermatologist that they can consult with or not? And as well, I have received many, many emails directly, and I never mind that, by people like, what do you think? Is it going this direction or that direction? And, and I'm telling them, no, that doesn't look like lupus, that doesn't look like dermatomyositis. Also, dermatomyositis tends to happen very early in life, relatively, but there are some adult onset that we are still probably trying to figure out. But I would say, since the condition hasn't been investigated to that depth, except I'm talking about genetic risk, which is probably the latest research in 2017, we haven't done much regarding the clinical characterization or the pathways and molecular and immune markers. So that's where it's all going now. So hopefully, with the future studies that we do, we'll have far more data and far more understanding of this. Yeah, I'm not sure if there are any questions further, or comments maybe, or any other insights. Absolutely, we are open to any suggestions.
None right now. The owner of the dog with the steroid is actually thanking you and appreciating your input. So.
Absolutely, no problem at all. All right, so I'm gonna move to the next one. The next question that I was given relates to what other autoimmune conditions are differentials. So pemphigus is probably our most common autoimmune skin disease in dogs, specifically pemphigus foliaceus. Now, pemphigus usually is very crusted or very driven by crusts and so-called pustules, which are like tiny bumps that are filled with pus, yeah? And when they rupture, because dog skin is relatively very thin compared to human skin, they tend to rupture very fast and produce crusts. So pemphigus does not look anything like vesicular cutaneous lupus. Also, dermatomyositis is not going to be pustular. It's not going to be so much crusted, and there won't be any pus in there. So it's relatively easy to differentiate. Epidermolysis bullosa acquisita, or EBA, usually affects Great Danes. It's a very robust autoimmune disease where you have footpad sloughing, oral cavity sloughing, so none of these will see. But absolutely, one of the diseases that we struggle a little bit is erythema multiforme, as I pointed out. It's called erythema multiforme because it's red, it's erosive to ulcerative, and it's multiforme, so it has different shapes, which can sometimes, not be an easy differential, not be an easily differentiated condition from vesicular lupus. The histopath of these conditions should differ. So when we biopsy, we should see differences there. So that's what we rely on most commonly. And also what helps us a lot with the breed, knowledge of the breed, the histopath, that helps us make a diagnosis. Now, a protocol, how to design a protocol, it would probably relate to the previous slide. I think we just have to keep on. I think it requires new, fresh publications, and then these publications, they have to reach out to our dermatopathologists as well as clinicians, maybe through clinician brief, maybe through some of the more. They don't have to be like research publications. They can be clinically oriented publications. And that you can post, and then people can relate to their veterinarians as well if they have time to read because the owner suspects this disease. In there, we would probably write, the clues and things, how to differentiate the conditions and how the conditions look like. That would probably be the best way, I think. But in the end, I relate that, as much as you get education, you can always relate that to your veterinarians as well. If they're willing to learn, they will always learn new things. Absolutely. So I would probably say that on that topic. Don't have much here more unless there are any comments or questions.
So we do have a question. An attendee is asking if there's any evidence that pemphigus is an inherited condition.
Well, I would say that all of at the time, no, for dogs, but I would say that logically, likely all these autoimmune diseases, there is some genetics there. So what we people, I guess, still try to breed collies and shelties and Shetland sheepdogs by trying to avoid the high risk genes, or proposed by Dr. Leon Clark. In the end, there are some genetics there. Now, how do these genetics play out in multiple puppies, and will everyone get it? We do not know, but likely there are some genetics possibly playing a role there. We just do not know all the features. And I would say the same thing with allergic skin disease. The inheritance varies between studies. In some studies, with West Highland white terriers, it's almost like 50% believe that the puppies will have it. But we just don't have all these great studies on this to follow. And it's easier to do that in more common disease than pemphigus because it's such a rare disease. So we don't have any evidence, but possibly if you have pemphigus, you probably want to think about whether some of the puppies down the line, if mom has it, whether they could get it or vice versa. I mean, that can happen. Yeah. Is there perhaps another question?
you.
Or
So another question. So first we have one of the attendees. You answered their question on Apoquel versus cyclosporin, and they're thanking you for your input. And then another one. For the past 3 years, I've been treating an allergic skin condition with chlorhexidine and ketoconazole, I believe, antibiotics when necessary, gentamicin sulfate, and betamethasone valerate spray, and Apoquel. They're working on a natural diet instead of manufactured food. How do you boost the immune system instead of using drugs?
Well, I'm not sure if it's been 3 years. We usually, if it's not food related, we will do allergen immunotherapy in patients. So we would test the patient for different types of allergens, usually through the skin test, and sometimes in addition with a serum allergy test, and then we'll try to basically reverse back the dysregulated immune system to the allergens. Because giving medications, it's usually just a symptomatic therapy. So we are trying to basically do the allergen immunotherapy, just like in people with asthma. It's the way to try to really go to the source of the disease. Now, if it is a food issue, then I would work with a nutritionist. There can be issues with recommending different types of food, and nutritionists are usually the people that we work here with that help us tweak the homemade diets if that's the goal here. But they are also not cheap to do that. So that is not so once they make that for you, you probably want to follow, because they tend to cost some money to invest into making that. Now with the diet and any type of food causing a food allergy on the skin, the data are all over the place. In our experiences, and we have done numerous diet trials for atopic dermatitis in dogs, and in general sense, the diets don't make a huge difference for us as a food allergens. We just don't see that. And we have done studies and studies with ultamino, elemental, and various amino acid-based diet trial protocols, and we just don't see that. But there are some centers that will report and rely on the food as a causative agent. I think usually if that's the case, the owner usually tells that immediately. They fed chicken and the dog has a rash the next hour, yeah? But if you're not seeing that, then I would wonder about that part, but I'm not sure. And also, I'm not sure if the owner is seeing a dermatologist, but if it's been several years and they're not successful, I would sometimes recommend to go and see a dermatologist. And then they may tweak some things or do allergen immunotherapy or something.
Thank you. There's another question about a case where their dog had a skin condition. They went through multiple biopsies, additional tests, got referred to one specialist and to another specialist, and the dog's healed, but they have some scarring. It turned out it was a fungus. How do you feel about maybe a way to better diagnose these dogs with very like weird skin lesions that are refracted to treatment?
I would say that being a person here, yeah, just like everyone, and I personally have a rheumatic disease, and after passing 2 years of being not diagnosed appropriately, I would say that you're still better off in veterinary world than you are in the human world. So sometimes it's a very sophisticated process. Unfortunately, it takes time with some diseases that are tricky. Sometimes they don't find the fungal organisms on the first biopsy, and then they try to treat that, and then they find them on the second biopsy. But with the human medicine, I would say it's the same thing. Sometimes you visit a doctor and they think it's this, and they treat you for months and you're not getting better, and then you go somewhere else and they treat you for months and you're not getting better, and then you seek. And usually, if you don't say anything, it's usually up to you to find. I mean, I figured out my stuff by myself at the end almost, yeah. But I would say that I, as an owner, and I have dogs and cats, I would say you need to be persistent, and if it doesn't make sense for you, you should say something and say, this does not make sense. It's not getting better. We need an answer. We need something else. What do you recommend? Where should I go next? And that's the only way to deal with any of these hard, very, I would say, very refractory cases that are hard to diagnose. Otherwise, it's not that I'm saying one doctor is better than the other one. It can happen everywhere. So it can, we have had cases of pemphigus that were not diagnosed by a dermatologist, but diagnosed by us to have pemphigus. So it's just, that's how life is. It's a long day. People try their best, and sometimes the biopsies they collected may have not given you or given the pathologist the clue that the fungus is there, and that happens. It's not always, I would say black and white. So, but I think the persistence is the only way. I mean, you just have to. If it's not better, you look at your dog. It's not better. You need to react. Just don't ignore it, and don't just like say, oh, it's gonna get better in 10 years. Yeah, no. If it's not better, ask what's the expectation. 2 months, not better. What do we do next? And that's what I would do. You just have to fight through it. It's unfortunate, and I'm sorry that happens, but it can happen.
Thank you. Have there any been studies of correlations between physiological or environmental stresses, including viral infections, as triggers of cutaneous autoimmune diseases?
So not much regarding the stress itself that we have studied. The vaccines, absolutely. We have some evidence for dermatomyositis, and that has been presented and published already. So absolutely, there is a greater risk with the vaccines to get, let's say, dermatomyositis in collies and Shetland sheepdogs. Whether they will all get it or not, I guess that's a good question and doesn't have to happen. But vaccines are known to be triggers, and vaccines are usually viral, yeah. So sometimes bacterial as well, but you have a lot of viral vaccines, yeah. So from that perspective, depending how they are composed in there, they are the ones to know to trigger the immune system. You're triggering the immune system, yeah, just like, when we used to get COVID vaccines and stuff like that. So that's for sure known. Now, if, whether we see a patient that gets, let's say, feline herpes virus is so prevalent and almost all cats have herpes virus, are they now predisposed to have an autoimmune disease? We would say probably no. It's not always do the viral diseases lead to autoimmunity, but depending on the individual genetic background, I think depending how you behave to the vaccines, that can trigger certain things. So I would say vaccines are probably our biggest, among the bigger ones that we keep an eye on.
One attendee is asking if there are any promising areas of research on DMS.
Well, one of the things that we would like to do with dermatomyositis actually is start comparing it to the lupus. And second part is we wish to collect more samples from these patients to try to understand how do the immune cells actually, who calls who and who does what to damage the vessels. We do not know that now. We can see the rough picture, what happens in there, and we understand why JAK-STAT pathway is upregulated. But that part is what do these endothelial cells in the vessel actually do and why do they attract immune responses? It's something that we do not understand. The only way to do that is to really get samples and store them appropriately, which we have to freeze the samples in -80 Celsius. And for that, we need patience, and we need patience here at UGA. Because it has to happen ASAP. It cannot be done after days of collection and stuff like that. So absolutely, we wish to study the dermatomyositis, and we also wish to evaluate more of the other JAK inhibitor to see over a period of month, does it give better effect maybe than what we have seen with oclacitinib? It's possible it may give, but we'll have to assess the health, the blood work, and the health adverse effects and stuff like that. So absolutely, that would be the next goal that we are planning to do.
Awesome. And someone's asking, their collie had VCLE lupus, and their litter sister had immune-mediated hemolytic anemia. Is it common for different autoimmune conditions to occur within a litter or passed down in generations?
But, I mean, I am not sure 100%, but I would say yes, it's possible. I mean, if there are some genetic risk, it's possible. Although these two diseases are relatively different in its pathogenesis. So one is driven by autoantibodies that kill red blood cells, and lupus is not autoantibody mediated. It's more a T cell driven disease. But yes, if there are genetic, background, and then somehow those genes get combined in a risk factor, and there is some kind of a trigger that can happen.
Thank you. There are no other questions at this time.
Okay, perfect. So, okay, so the next is before and now, and I'm not sure how much time I have left because we are running out of time slowly. Is this the last slide? I do not know. Just check it. Oh, okay, future work. So what we have known is that before we started working, at least with dermatomyositis, our treatments have been usually related to pentoxifylline, which can sometimes help or not help depending on the severity of the case. Also, people have been using, of course, steroids, but many times the dogs would just have scarred lesions and nothing would work and the patient would live like that. In early 2010, 11, we have sometimes utilized cyclosporin for these patients and topical tacrolimus, but even that would not always help. So once we started evaluating the dermatomyositis, biopsying these patients, sequencing the skin, and figuring out what happens immunologically in there, we started implementing JAK inhibitor Apoquel as one of the first-line drugs. And what we have seen is that it absolutely makes a difference. Sometimes even some of the scarred lesions will get hairy growth, sometimes not fully, but the patients feel the lesions always look better and the patients feel always better because some patients also have muscle involvement, so they are not going to be like running around. They'll feel a bit off, basically, because of the immune dysregulation. So what we have done then is this has been like presented, and then people have generally like started utilizing this in various other conditions that resemble dermatomyositis. And that's kind of one of the things that we tend to do for any type of similar diseases, including dermatomyositis. They all belong to this vessel damage, which we call vasculopathies. And that's where we have started treating them. Now, there are some patients that don't respond fully to that, and that's the question that will be answered hopefully soon. Why don't they respond? But we would have to start collecting their skin biopsies to figure that part out. The most difficult part of the project is usually getting the patients in here. That's what we have had the issues with. So we generally have to rely on a lot of communication via emails and photographs by the veterinarians as well as the dermatologists that are collecting these for us. But the biggest challenge is usually getting the patients in here, because if we could get the patients in, everything would be much easier for us. We have had patients that drive several hours to get here, but we are still far away from, for many patients, unfortunately. Now, where do we go from here? Well, we would say that absolutely, if anyone has a coli or a Sheltie with any of these diseases, we always appreciate if they could let us know. We would be trying to collect their samples, like meaning if they are going through a biopsy, we would try to collect some of that biopsy samples. Ideally, they would come directly to us, but if not, we will work in our capacity with whoever is collecting these, because we would just submit certain tubes and certain materials so that they know what to do and where to put the samples. We are still sampling DNA swabs from colis and Shelties with vesicular lupus, but we have not done the same thing with dermatomyositis. But since we are going to collect dermatomyositis, we would run those as well. So once they get submitted to us, we usually forward those to Dr. Leanne Clark, and she will analyze these and tell us what her findings are. It usually takes a little bit of time to get those because they're not going through a commercial lab. Those are probably the most important information I have. So basically, if anyone has this disease or knows anyone who has this disease, absolutely, we would appreciate if you could share our email and connect us. Even if the patient is on treatment, we don't have to collect just to know what type of treatment it is, and if it's helping or not, we may be able to help the patient, tweak the treatments by talking to the primary veterinarian or the dermatologist. Affected senior unaffected dogs. We generally have not collected a lot of unaffected dogs. Several of them did come here for sampling as our controls, but I'm talking about like 4 or 5. I'm not sure that we would need more than that, but I guess we would have to talk to the foundations to figure out if they can find some local dogs for us rather than that someone travels if they are healthy adult dogs. And absolutely, for the funding and from the foundation, it has been detrimental to understand the dermatomyositis, what we have done so far. I'm hoping now with the future work that we do and getting a PhD student to get on board to publish several of the papers we have to get the data out. The biggest challenge for us is usually getting committed person because I have to do the clinics and I supervise the lab. It just becomes a lot of work to try to publish at the same time and try to write the grants, do the work in the clinic. So absolutely, with the help of the foundation, we are hoping that the next year will be really a good year for us to get all of our data out and start doing the second studies and collecting more patients. Now, individual owners, like I said, the best way, if you can let us know, if you know anyone or if you any information worldwide, we can reach out people, and who has active patients, if they are willing sometimes to come to us, that would be great. There is some talk, and I'm still figuring out how we can support traveling to our institution. But I think the foundation will help more to clarify that in the future months to come, because there would be a way that they can help funding some of the trip or the trip, so that way that it doesn't turn out to be very expensive for people to travel. Because that is I think that's the major limitation we have. It's a bit different in the medical field. They don't have that. Sometimes people will travel hours and hours to get seen by a certain expert. I understand that that's not that easy for the work we do. And then trying to summarize, I would honestly say after being 10 years of faculty is that basically research is the key to improve lives of our patients. If you do not do it, it will turn out to be, very non-science driven and very, I try this, I try that. But doing the research is the key to prosper the health of our pets and patients, and that's the only way to do it. I think I'm a little bit over time, a few minutes. I apologize for that. Since I guess I'm the first person, I wasn't sure how long it's going to really last. And we did start, I guess, a little bit later. But happy, first of all, thank you for inviting me and for making this happen. And I'm looking forward to our future work. I would like to thank Nancy and everyone else involved and the whole foundation, including our moderator here. And then if there are any other questions or comments, happy to answer. And if people need my email, I'm not sure how they can share that, but I'm pretty sure you can find me online, or we can share that email to all attendees somehow if you have any questions or any comments. Thank you again.
Well, thank you very much. And we are really looking forward to continuing our research over the next year with this new project that we're imminently voting upon on DMS and the vesicular lupus. And yes, we are working on helping with travel expenses in some cases. So your point of getting people to spread the word and contact you is going to be critical in getting more potential candidates for these studies.
Yeah, absolutely.
And Roxanne, I think we do have his email address on our website under the previous
Yes.
research.
So I'm going to have a shameless plug. If you go on the CHF website under CHF Research, there's a page, Participate in CHF Research. And in the different grants on this page, those are active grants that we're funding, you will find Dr. Banovic's grant. I believe it's at the bottom with his email on there. I think we have 2 questions left. Do you want to answer real quick before we wrap up?
Absolutely, sure.
So the first one is, do the biopsy samples have to be of acute or active lesions?
Ideally, yes. Ideally, yes.
Okay. And then there is an attendee from Argentina who said that her dog had a first episode of dermatomyositis when she was 4 months old. She tested for the DMS risk and it came back as moderate risk. They were never fully able to stop the flare-ups. So do you have any suggestions?
I am not sure how they are treating it currently, but I do have very good dermatology friends in Argentina. So I'm not sure where the person is exactly at, but there are some board dermatologists there. And if you would like to email me directly and just put some pictures and history, and I can see how it looks now and what you're currently giving, then I can give you a little bit better feedback or connect you to someone there, depending where you are. But in general sense, we do think that this can be largely controlled these days based on our experience. But I would need to see how it looks like and what they have done to comment more.
Thank you.
And we'd really like to get some of that DNA sample to Dr. Clark as well on that. So that's great if she could contact you.
Yeah,
Yeah.
regarding this low, moderate, and sometimes we have had patients with low risk having DMS too. So it's not always 100%. It's a bit tricky, I think. Unfortunately, that's why it's not so monogenic. It's probably multiple genes, and you have to do the combinations for the risks. So that can happen too, just that the audience is understandable of that. And probably those samples would be valued too to understand why, because we really are hopefully we'll figure out that part, what's going on with them. And if they are somehow with their clinical lesions different than the ones with a high risk, maybe they have less prolonged disease or less severe. I'm not sure about that. That would be interesting to know. Absolutely. Are there perhaps any other questions or?
Not really. But as you said, like samples and participation are so important. We have multiple grants that are currently requiring samples and participation. So please go to our CHF website for more information about those.
Yes, and as this next grant gets underway, we'll certainly be putting more on our website on how to participate with that as well. And I thank you very much, Dr. Banovic, for spending time with us today and getting us started on these webinars. Thank you.
Absolutely. Thank you. Have a good evening. Thank you. Bye.
You do as well. Thank you.